Well, I think the neoadjuvant aspect of genomic profiling is really a key component to what this is all about as it relates to the surgeon and the multidisciplinary team. But the reason why is that the surgeon is the first line. So we're the ones that have, whether the diagnosis was made by ourselves or a core biopsy or whatever, but usually these are patients that have palpable disease or potentially advanced disease. And, they all could easily be mastectomy candidates. However, that's one of the benefits of neoadjuvant treatment is to downstage them so they can be lumpectomy candidates. And the additional reason for neoadjuvant treatment is to get a prognostic idea about the response to the treatment, whether it's endocrine therapy or chemotherapy. So the surgeon has to recognize that patient. If they don't recognize that patient as a potential neoadjuvant candidate, then they're probably going to do that patient a disservice, go ahead and do an aggressive mastectomy procedure, and then you lose all opportunity to see whether they're going to benefit from any preoperative chemotherapy. So the early results from some of the trials that were utilized to begin the validation process for Oncotype testing in the neoadjuvant setting are exciting. It does kind of correlate with what we already know about adjuvant treatment in that the patients that have low risk scores don't seem to benefit from chemotherapy, but likely benefit from endocrine therapy. And then the patients that have high risk Oncotype scores will likely benefit from preoperative chemotherapy and also are more likely to have a complete pathological response to that treatment, which then ultimately correlates with a better survival and a better prognosis. So I think it's an excellent opportunity for us as surgeons to identify those patients first and go ahead and use the core tissue to be evaluated for the risk score. And then I don't think a lot of us surgeons are going to be the ones to initiate the neoendocrine therapy or the chemotherapy, but again, let our patients know that this is being done and then hopefully educate the medical oncologist to go ahead and use these tools to decide whether they're good chemotherapy candidates preoperatively or endocrine therapy patients preoperatively. The problem is when you have these young patients that are 35 and 40 years old that have these ER/PR positive tumors, it's going to be a complete paradigm shift for the medical oncologist to just offer them endocrine therapy. But in the elderly patients that aren't good medical candidates to receive chemo, it's the perfect patient to use to identify what their benefit will be. So I think the neoadjuvant setting for genomic profiling is the next step and will be an exciting place to use this technology.